Morning, everyone. Welcome again to Acadicus. I'm Dr. Nick Slamon. I'm a pediatric intensivist at the DuPont Hospital for Children in Wilmington, Delaware. In today's tutorial, we're going to go over some very important but very basic concepts surrounding EKG. So let's start with our patient here, Simon, and notice that he's got 10 stickers on his chest, 10 leads hooked up, and he's hooked up to a Philips 12-lead EKG machine. And you may start off by saying to yourself, well, 10 leads, 10 stickers, how does that equal 12 leads? Well, those 10 stickers are looking at the heart from 12 different positions as the electricity of the heart comes and goes as it moves through the structure of the heart itself. So now that we've kind of unraveled the mystery of 10 stickers being called a 12-lead EKG, let's step over here and really get into what is this electricity that we're talking about, and what do you mean it's moving in different directions and the stickers or leads are looking at it from 12 different views. Well, here we have a diagram of the heart, and we have its electrical structure, and the pacemaker of the heart, the electrical charge that starts the heart to beating, comes from number one, the SA node, which is located somewhere in the right atrium. And that SA node has its own automaticity. It says you're going to beat at this rate, and we have our big and large chart here, beating, and everything starts from there. Now, electricity in the heart could move cell to cell, and that would be highly inefficient. What we want to have a concept of, or what we want you to start thinking about, is electricity moving through wires, whether it be telephone or coaxial cable for your cable television, or it's always more efficient to move through some kind of electrical conducting system. And the heart has that built in. So that initial cell, that pacemaker, that SA node, starts the electrical charge, but then it starts to conduct through this embedded wire system through the heart. So the SA node beat travels down the atrium to the AV node, shown here in number 2. And the AV node is the gate. The AV node's job is to make sure that the conduction from the SA node is delayed just enough to allow for filling of the ventricle. The worst thing in terms of efficiency for your heart would be for that right or left ventricle to eject when it's half full or a quarter full or empty. So we want it to fill during diastole. We want it to be completely filled. We want the atria to contract and top off the ventricle with a little bit of extra atrial kick, as it's called. Then we want those valves to close, as we talked about in our structure lecture. We don't want blood ejecting upward, backwards into the atrium. We want it to go forward in the pulmonary artery and out the aorta. So the AV node is that gate that causes the delay in conduction until the ventricles are full. Once the gate senses that the ventricles are full, then we have conduction down the fibers in the ventricular septum, which is called the His-Purkinje system. And why don't we take a look as we step over here to the heart itself. On our enlarged sectioned heart, you can see those fibers kind of running right down here in this white line in the septum. And if you really get close, you can kind of see they fan out like a frond. They have these little finger-like projections so that they cover all of the ventricular tissue and get it to contract in concert. So that goes back again to that concept of an insulated wire allowing electricity to go very rapidly from place to place. If the electricity in the heart went from one cell to the next cell to the next cell to the next cell, that would be very slow, and it would cause severe alterations in the synchrony, the coordination of the contraction of the atria and the ventricles, the filling, the closure of the valves. It would all get thrown off if we went cell to cell to cell. So we have this wire system, we have this insulated cable, SA node to AV node to his Purkinje system, and we want to use that. So the next part of this talk, or the last part of this talk, will be to focus on what's a normal EKG going to look like. So Simon has his 10 stickers, his 12 leads, taking a look at this electricity moving through the heart from 12 different directions, and that's going to generate an EKG. So we have a classic EKG here in this poster that gives us the P wave, the QRS complex, and the T wave. There's also intervals and segments that I can talk about at another time because they'll give you ideas about what's normal and what's not normal. But in general, we want an upward deflection of the P wave, that first bump, and that's going to represent atrial depolarization. The atria having its electrical charge in its contraction. Then we have this QRS complex, which has a Q wave downward initially, then a sharp R peak, comes down into an S wave and comes back to the baseline. And the QRS complex represents the contraction of the ventricles. It's not really left or right, although depending on what lead you're looking at, you could focus in on a certain part of the heart and say, oh, those are the anterior leads. That's the anterior part of the heart, or that's the left lateral part of the heart. So you can get an idea when you have 12 different pictures of the heart's electrical activity, where exactly are we looking at? And that becomes important in adult medicine, of course, for ischemia. So if you have lack of oxygen to a certain part of the heart, the EKG in that part of the heart is going to change. So you can kind of pinpoint and narrow in. But our QRS complex in general represents the depolarization of the ventricles. Then we come back, as I said, to baseline, and then we have the T wave, and the T wave is important because that's resetting the system. That's the repolarization of the ventricles. They're getting ready for the next contraction. So that's another important point that we should point out before we finish up. We have this normal SA node to AV node to his Purkinje system. There are occasionally what are called bypass tracks, abnormal wiring of the heart, where sometimes you may have a stimulus that allows electricity to go back up and stimulate the SA node to beat again before it's ready to beat. And that could be atrial fibrillation, that could be atrial flutter. And again, the heart really depends on that AV node to be the gate and say, well, yeah, that's great that you have another beat ready to go, but the ventricle isn't full, the valves haven't closed, I'm not going to let that conduct. Unfortunately, there are certain diseases, supraventricular tachycardia, especially prevalent in pediatrics. It's one of the ones that we see more often. Adults see AFib and aflutter, but sometimes that gate fails, that AV node fails, and that conduction goes to the ventricles, and then they begin to beat very rapidly. And again, that AV synchrony, synchronizing the atria and the ventricle to allow for complete filling and top off, is key to efficient cardiac function. So I hope you enjoyed today's tutorial on the basics of electrocardiogram and EKG interpretation. We'll see you next time.